if you're dual diagnosed, then heaven help you, because if you're a drug addict, there's a stigma. If you have mental health problems, there's a stigma. So it's two stigmas in one.
I expected them to make me, well, to treat my condition as they would do a broken foot, you know, to mend it, and very early on I realised that wasn't going to happen.
I was more or less just turned away and asked to come back when I was feeling better, which I thought was odd. I went to see my doctor several times after this, and he mentioned the hospital, and I didn't ever use the hospital again.
When I found powerful street drugs, I thought I'd found the answer.
My experience of mental health service was one that I didn't really want to experience any further.
When somebody goes onto a ward to be treated for a mental health problem, if they're also using drugs, they're very afraid to admit the misuse of drugs for fear of being arrested. One of the witnesses we spoke to told us an amazing story about sniffer dogs being brought onto a mental health ward to sniff out illicit substances. And if people were caught misusing drugs on a psychiatric ward, then they were likely to be arrested and taken away.
Dual diagnosis as a term, to me it's a professional term. It's a word that professionals will understand, you know, and when they say dual diagnosis, it normally means mental health and substance misuse.
If you look at the literature, it's a bit of a narrower focus, and it means people usually with a psychotic disorder, or sometimes just people with schizophrenia and who are using drugs or alcohol.
Medically, I think, and for professionals, it's a term that we all understand, but I don't know if the actual people we work with understand what that means.
It's a way of suggesting there's problems without addressing them. And I think even when I'm at my most buoyant, I've got more than 2 problems.
We've done a study recently in South London, and we contacted everybody in a particular area with any psychotic problem. Psychotic means, for example, schizophrenia, manic depression, things like that. And then we said, do you use any drugs or any alcohol? And 30% said yes. So we thought, aha, very common in the inner city. So we did exactly the same study in the suburbs, and again the result was 30%. So it looks like it's not as if it's just an inner city problem. It's very common wherever people have looked.
Substance use can aggravate an underlying vulnerability to mental illness, but there's no real evidence in any of the research that it actually causes mental illness per se. And certainly if somebody's already feeling quite distressed, agitated, anxious, paranoid, substances will just generally enhance whatever mood somebody's in anyway.
What is causing what is one of the key problems in the area. Probably all the possible relationships are true for some people. For example, that mental illness is causing disorganisation, and then people are picking up drugs or getting involved in a drug subculture for some individuals. And on the other side, that for some people, using drugs is the starting point, and those drugs can cause mental health problems, sometimes depression, for example, sometimes psychotic symptoms, and then the two get mixed up together.
The studies that have been done have all reported similar reasons why people with mental health problems use drugs, and that is largely to facilitate social interaction, to take away the side effects of their prescribed psychiatric drugs, and to enable them to focus away from the symptoms that they're experiencing.
I was taking street drugs as a short-term fix to the way I was feeling. Any slight lift in my mood that antidepressants might give was nowhere near enough.
When people sort of perceive clients with mental health problems using drugs, they usually see it as quite a detrimental thing to their health, as almost a sabotaging action. People forget to ask the reasons why somebody's chosen to start using and why they're continuing to use despite adverse consequences.
I know people on the street that I would assume had very serious mental health problems, which they managed to keep a lid on with street drugs.
We say to them, actually, you mustn't take your drugs because they're bad for you, and you know, they're from bad people and they do bad things, but here are our drugs, you know, these drugs are okay. And we don't really subjectively understand what the experience of taking psychiatric drugs is.
They produce horrible side effects, for example, licking your mouth, this type of thing, rolling your fingers, pill rolling behaviour it's called.
The trouble with a lot of the medication that's prescribed by psychiatrists is often the symptoms that they're treating the client for are not necessarily the symptoms that clients complain about most. For example, somebody with schizophrenia, they're more likely to report distress about their mood and anxiety as opposed to actually voices and paranoia, which is what the services are trying to treat.
Often they drop out of services, and what they're doing is they're finding other ways, and the other ways is using, you know, it may be cannabis, it could be sulfate, you know, it just depends what they need. You know, they find it quite helpful to get them out and about, so why bother with the side effects from the prescribed medication?
It doesn't appear to be any harm being done, but of course you can become dependent on the drugs. You come into contact with the law, people you wouldn't normally associate with, dealers and that sort of thing. And of course the health sort of aspect.
Let's say your thoughts are getting muddled, you're hearing voices, then it may be very difficult to keep any degree of control over what's quite a complex social role, to get the money, to buy the drugs, to avoid the police, to keep your habit going without having, you know, withdrawal or getting caught at it. From the point of view of the mental illness, quite often the drugs are going to make the symptoms worse. So for example, quite often amphetamines or crack can encourage people to feel more paranoid and suspicious. So if you're already suffering from paranoid schizophrenia, the last thing you need is anything to make you feel more paranoid. In situations like that, I mean, at the least it can make people withdrawn or guarded or, you know, become a hermit. At the worst, it can make somebody so suspicious that they're, you know, just a fuse, a bomb waiting to go off.
If you think about how the general public perceive people with mental illness, they're perceived as dangerous, they're perceived as difficult, manipulative. And if you think about the way the public perceive drug users, they're perceived in similar ways. They're perceived more, though, as manipulative and as criminal and robbers. And I think when you combine those two ideas, you've created the ultimate social monster.
Often they're getting admitted to hospital. They stay in hospital twice as long as patients who've got a psychotic problem but who aren't misusing drugs or alcohol. And they're about twice as violent as your average psychotic patient. So from a staff's point of view, you do not queue up to try and help this sort of person. And in fact, if you're left alone, you might try and avoid those patients, you know, if you possibly can, because we don't really know what's effective to help them, and they're difficult and truculent and troublesome and challenging characters.
And that's really how people with dual diagnosis are perceived by services.
They just see the problems and the aggro and the intoxication and the aggression, and they don't look beyond what's that, and often that's their only way of communicating is by being quite abrupt and aggressive.
As soon as you mention drugs, which I'm honest, you know, I do want a diagnosis and a treatment which is going to work. So as soon as I do mention the drugs, and of course the mood changes and there's a swing towards treating the drug use.
They're in dire need of help, and often they go seek help, and because of the way they behave, because of how they are, they're often sort of shunted to another service, and they give up because they're just not getting heard.
An adult mental health service may say, your main problem is the drug problem, you go to the drug centre and, you know, you come back to us if you only have a mental health problem. The drug centre will say, your main problem is the fact that you're depressed and you're drinking because you're depressed. You go to the mental health centre and you come back to us, you know, if you're still drinking without being depressed.
I've experienced a sort of pass the buck attitude with both psychiatrists and drug treatment centres. In mental health services, you need to be clean, and in a lot of cases I have been clean. But there's drugs on my record, and it does seem it's easy for them to say, well, that's the problem, you know, and off you go. And again, with drugs, I've been sent to treatment centres where the psychiatrist has said, right, I want you off of all this medication you're on. And I've just crashed.
This is a new group of patients presenting new challenges to the service, and in effect they're a type of mental health underclass. Some of these people find that they're not quite bad enough, quotes bad, to satisfy the criteria for any single agency. So for example, they may have mild ideas of suspicion, but they're not clearly psychotic. So a mental health service might say no grounds to establish definite mental illness. They might have been to prison for a few months, but not long enough to have been followed up by the probation service. They may have been squatting with a friend, but they're not literally homeless, so the housing department doesn't have to get involved. They may not have any particularly clear reason for social services to have to allocate a social worker to the case. So what happens is that they can actually just fall below the threshold for all the helping services and get nothing, even though they might have 5 or 6 or 7 major problems at one time. It means that they have a dreadful quality of life, and they're either getting no help or bits and bobs of help that's actually not part of a coherent pattern.
They're often seen as having brought their problems upon themselves, and I think this gets to the crux of what we're talking about here, because you've got two very different models. If you're talking about people with mental illness, then you're talking about the sick rot model, in which people's responsibility is taken away from them, they're given treatment by a doctor, etc. But if you're dealing with people with drug problems, the current treatment, the thinking around treatment is that people need to take responsibility for their own drug use and responsibility for the problems that's brought on them. So these are two very different models which rarely come together, and certainly if you're the client in the middle of this, trying to get help from both services, you're often receiving very contradictory messages.
From the drug and alcohol field point of view, a key element is motivation. You've got a problem, it's your problem. You tell me first if you recognise you have a problem, and B, if you're really motivated to deal with it. And if you are, then I can help you. So that's very clear cut. Now, from a mental illness point of view, it's not nearly as clear cut, because we talked about insight. A person may say, well, the drugs are causing me to feel paranoid, but they also help me to sleep, so I'm not sure I want to carry on, but I get some benefit. And if you say to the person, do you recognise you have a problem? They'll say, well, not really, no. Do you want to do anything about it? No, I quite like the feeling I get when I'm taking the drugs. So if you adopt just a motivation approach, it just breaks down immediately when you come across people with a substance problem and a mental illness.
You've got to work quite holistically, really. When somebody comes in and you do an assessment, you've got to find out, you've got to go right back, really, to childhood. What's happened in their life, why they're using drugs, what do they get out of it, what's the good things about using the drugs, what's the not so good things about using the drugs.
The approach to this is so-called motivational interviewing, where you then amplify in the person's mind the disadvantages that they're experiencing. When they talk about advantages, you say, oh, well, you're sleeping better when you take the cannabis. Okay, well, there are other ways we could help with the sleep. So what you do is you shape the person's view about their situation by de-emphasising the advantages from the drug use and by amplifying the difficulties that they're reporting.
You've got to get the whole picture. What are you doing? Are you sharing needles? Is your diet okay? What's your housing situation like? And then start trying to work out, make a plan and prioritise what you're going to do first. The main thing that people worry about is, have they got a roof over their head? You start with the basic stuff, get that sorted out, and then concentrate on the other stuff.
People with dual diagnosis are not that different than other people. There are some specific skills that are perhaps helpful, like motivational interviewing, but really probably the most important thing is establishing a therapeutic relationship, a therapeutic alliance with that person and engaging them properly.
I try and work with what's presenting at the time, and I think the best way, the way I find useful is the harm minimisation rather than abstinence-based, because that's often what you're getting if you're going to psychiatric services. They're saying you must stop.
The approach Maggie has as opposed to the other services is a psychiatrist will dictate to you what is wrong with you, what form your treatment's going to take, or what you should do to get well. Maggie, which is refreshing, actually says, what are your problems? And starts giving me a bit of power, really, back to my own existence, whereas before everything's been done to me or on my behalf, and I'm actually got a sort of a major part now in managing my own life. Maggie was on the ward round and saw how frustrated I was and approached me.
I did a brief assessment and made an appointment to go back to look another way, where he didn't have to go into a rehab and he didn't have to go back into hospital, so we planned how he was going to manage in the community. The main thing was to engage with him and get build up a bit of a rapport, because he felt he's been let down for so many years. And then once we got the trust built up, it was more like, well, what is the real problems, what's going on? And a lot of it is everything's just getting too much.
It can be something which would seem quite minor that I'm struggling with, but it depends on my mood.
Bills piling up in the flat whilst he's in and out of hospital all the time, because he's in, then he tries to sort himself out. When he gets out again, then he's back in again. So he's in and out like a yo-yo.
I get very easily overwhelmed. Maggie will actually put it into some perspective and give me or suggest a running order or a way to actually achieve goals.
I just see loads of brown envelopes on the mat, and they're not going to bother. And before you know it, you're getting repossession orders. So you're going to be homeless. And then you're going to be on the streets, and then you're going to be mixing with your drug friends again, and you're going to be doing criminal activities to get the money. So then you're going to be in trouble with the police. So the basic stuff like keeping the housing, sorting the electric and the gas, getting the money in to pay them.
She doesn't do them for me, but she will help me or support me in doing it myself if it's all possible.
And then concentrate on the other stuff, a bit of relapse prevention, a bit of motivation, like looking at where you are now compared to where you was a little while ago.
Things that held a great deal of fear for me in the past are sort of slowly falling into some sort of... they become more realistic. They're not overwhelming fears which are going to sort of instill panic in me.
If somebody's just about to have the electric cut off, then that's, that can be sorted out with a phone call. But a week later you could go back and it could all change. You've sorted out a couple of little things, and then you say, okay, this is a plan for next week, this is what we're going to do. Like, we might have to fill in some benefit forms or something. But there could have been, could have had a relapse. So it's all changed for that week, but you just keep plodding away. You've got to be fairly flexible and work on client terms, really.
Things are becoming more achievable, and slowly but surely I can, with sort of affirmation of family especially, who say that they've noticed a great deal of change, I'm feeling positive.
The rise in use of illicit substances has been quiet, although significant, and I don't think the people in the mental health services have realised the scale of the problem. I don't think the politicians have realised the scale of the problem until the last couple of years.
Drug use is a ubiquitous phenomenon. It's always been around. It's been around from day dot. It will be until the end of the world, probably. And so actually what we need to do is look at using harm reduction approaches with this population, which target them where they're at now with no kind of hard and fast rules, and try and make their drug use safer.
I think mainstream mental health services and drug services, I think they're pretty scared by dual diagnosis. They feel that the person needs to go away, like drug services send them to mental health to get fixed, get cured first, and mental health send them back to drug services to say get clean or dry.
So there has to be somebody in each organisation above that to knock heads together and say, you may or may not want to treat these people, but as a service we have a responsibility to respond, and we are going to strongly encourage you. If necessary, we're going to require you to have to work together to do our best to help this particular patient group.
We've got this term dual diagnosis, it's just another label, really. But when you actually get down to the nitty-gritty and you start speaking to people and listening to what they're saying to you, there's more than one problem.
Dealing with patients who are dually diagnosed is a very intensive business, and we turn to resources or lack of resources. We need more professionals training to deal with it, because you need almost a one-to-one basis between the professional and the patient.
There's an awful lot of money spent and people doing the revolving door. They're going in, detoxed, rehabbed, out, crash, back in. Where I feel somebody like myself, not just saying me personally, but more workers like myself, need low caseloads, because it's quite intensive, it's quite stressful at times, so you need to have the time to spend listening to what's going on and making an effort to be there. You know, it's meant to be 9 to 5, sometimes it's after that. You've got to be flexible, but it's a cheap resource because all you're doing is paying my salary. Very rarely do I have to purchase other services. So it's wages only and time and listening to people. So I think we could do with a lot more of that, really.
Meg been working with me over a year, and I've not been in residential treatment since we started working together. Prior to that, I don't think there was a year where I wasn't in receiving some form of treatment. It's quite an achievement.